Welcome to the Queue. My name is Nurse Bugg. I'm your friendly neighborhood nurse surveyor.
Welcome back to the Q's podcast, your go-to source for everything nursing home professionals need, from compliance and care to best practices and practical tools. So today's episode is all about MDS optimization, a crucial topic for every SNF, whether you're an MDS coordinator, a DON, or part of the IDT. This episode will help sharpen your approach, ensure compliance, and maximize efficiency. So let's dive in. You always want to engage the interdisciplinary team, the IDT. So optimizing your MDS starts with a true interdisciplinary approach. One person really can't do it all. That's why organizations like AHCA and NCAL emphasize training the entire care team, nursing, therapy, social services, and even ancillary staff. You want to hold daily or weekly IDT huddles to ensure communication flows. There's always breaks. The minute you start having a break in the schedule and you don't do something scheduled, that's when those communication flows break down, and that's not needed. With the EHRs we have nowadays, it makes it easy to follow up on what you missed, but those face-to-face huddles mean something to your staff. So just make them a priority. Let therapists report on GG items. Social services contributes to mood or cognition interviews, and nursing tracks ADLs and skin issues in real time, nursing and CNAs and nurses. You want to embed data collection into daily workflows. So make data collection seamless. Many EHRs nowadays support POC charting. So let clinical staff document care tasks like meds, wounds, or toileting at bedside via mobile devices. The faster they can get it into the EHR, the more they're going to do. Because nobody wants to come to the end of their shift and have to fill out and document and do all that. So just make it as easy as possible. Let CNAs and LPNs enter initial data. So like fluid intake or behavioral observations, right as it happens. Then your MDS coordinator can validate and code it. It's not just efficient, it's accurate, it's timely, and it makes it CMS ready. So really, you're killing two birds with one stone right there. You want to standardize documentation and checklist. So use structured documentation and checklists to capture what matters. And implement triggers like alerts for new infections or pressure ulcers to help your team know what to flag for upcoming MDSs. And use carry forward features in your EHR cautiously, though, making sure that the data is updated and verified by a human. Automation saves time, but oversight ensures accuracy. You want to rigorously schedule resident interviews. Follow CMS timelines by the book. It sounds like a duh thing, but if I was an MDS coordinator, I would have a calendar on the wall and it would be filled with residents' names that I need to do for that day. And I would make sure that ARD date is being watched like a hawk. So assign clear roles for each component. For interviews like the PHQ-9 or the BIMS, you want to schedule early in the look-back window, as it must be done on or just before the ARD. Use support staff to coordinate and prep residents because that keeps your schedule tight and your data valid. You want to commit to continuous education and auditing. So regular MDS audits and staff training should be the norm, not the exception. Use boot camps, quizzes, and orientation modules to keep your team sharp. Create audit routines and stick to them, or known as clock audits for submission timelines, or code audits to cross-check MDS items with documentation. And administrators, stay involved. MDS accuracy impacts QMs, 5-star ratings, and reimbursement. It's not just an MDS coordinator thing. Everyone needs to be a part of it. You also want to leverage technology for MDS success. So platforms like Matrix Care and Point Click Care's PDPM Coach make MDS workflows a lot smarter. These systems allow staff to input data at the POC, which then auto feeds into the MDS. So Sunmar Healthcare, for example, increased their CMI by 6%, and they saw a 20% jump in Medicare revenue by ditching spreadsheets for PDPM Coach. And don't overlook analytics and scrubbing software that scans MDSs for errors, pre-submission. Fewer mistakes mean faster reimbursements. And faster reimbursements means you can better care for your residents because you're paying everybody, which is great. Now, I have a few case studies to prove that these changes and modifications work. John Knox Village in Missouri saw their star rating jump from 1 to 5 after allowing assistance scrubbing MDSs before CMS submission. UTIs dropped 60%, which is unheard of. That's amazing. And long stay pressure ulcers plummeted. Sunmar Healthcare reported faster, more accurate MDS work with EHR integration, again, leading to better revenue outcomes. All the information that your staff were that their staff were putting in was flowing over to the MDSs. So then the MDS coordinators just had to check it, make sure it was all right, and send it on. LifeSpace Communities standardized nursing assessments across 17 campuses, and the results: fewer rehospitalizations, better quality measures, and hours saved on regulatory changes thanks to auto-updating tools. Those are just 3 examples. So let's quickly review best practices. You want to follow CMS RAI manual always. Follow it to the T. Train your team regularly, especially with each RAI revision. They do make revisions. That's going to happen. Keep your in-services going and as needed. You want to enforce real-time documentation supporting MDS answers. So those bedside tablets or iPads or whatever you want to use, those really are best practice. I mean, you have to make sure that HIPAA and compliance and locking them, because people set things down. But once you have that in order, it's really going to make that real-time documentation so much easier for everybody, the nurses, the CNAs, therapy. I mean, the list goes on. You want to monitor quality constantly through QAPI with 7 internal audits. So QAPI's 7 internal audits, let's start with infection control. That's number 1. You want to evaluate hand hygiene compliance, PPE usage, isolation protocols, and adherence to F880. Anything F880. Focus during flu, COVID, and TB seasons. You really want to focus on prevention and education. Ensure proper documentation and training. Okay? So that's infection control, and that's a high-level overview for sure. The second one is medication administration audits. So you want to review medication paths, storage, expiration dates, and MAR accuracy. Help ensure compliance with F tags like F755 to F760. Include observation of staff administering meds. You'd be surprised how much you can figure out from watching one med pass. That audit is really simple but really powerful. The third area is pressure injury and skin integrity audits. You want to ensure timely documentation of skin assessments, interventions, and wound care. It aligns with F686, treatment services to prevent and heal pressure ulcers. Number 4 is notification of changes audit. This reviews timeliness and documentation related to F580, changes in condition, accidents, medication, and treatment plans. It confirms that residents, physicians, and family and responsible parties are notified appropriately and timely. Number 5 is care plan audits. This ensures individual, timely, and interdisciplinary care plans are in place, updated, and actually used. This connects with F656 to F657, and it also checks for person-centered goals and resident involvement. Very, very important. Number 6 is staffing and competency audits. So review appropriate nurse and resident ratios, training completions, and competency validations. Those audits are really important. You want to go out and you want to make sure that your staff know what they're doing with each resident they care for. That is part of the person-centered care. So it helps with compliance under F726 and QAPI Element 5, so systemic analysis and systemic action. Number 7 is incident and accident and falls audits. So you want to track trends in falls, injuries, and incidents to ensure root cause analysis is conducted. You want to monitor follow-up, interventions, and staff training to prevent reoccurrence. You want to support QAPI goals related to safety and risk mitigation. These are just a few extra things. Those were the 7 initial ones. You can kind of have some bonus areas to look at and customize it for your facility. So some facilities also audit resident satisfaction and engagement, dietary and hydration, survey preparedness, and mock survey audits, which QSource can help you with. Use technology alerts, third-party validation tools, and quality improvement organizations. Track regulatory updates, especially those rolling out every October. And this is where I'm going to say QSource can help. Do you need help staying compliant and efficient? QSource has RAC certified QI experts who can scrub your MDSs, train your team, and help ensure assessments are accurate, timely, and optimized for reimbursement. From auditing your current processes to hands-on training, we've got your back. Let us know. Come to the website, www.qsource.org, and click book a consultation. We want to figure out if we can help you, and we really can. I mean, we've had so many facilities come to us with questions about MDSs, new MDS coordinators that need training. It's nothing new to us. We've done this for more than 50 years now. So thanks for joining us on this deep dive into MDS optimization. Next podcast, we're shifting gears to talk about National Nursing Assistant Day, which is June 12th, and what you can do to celebrate your staff the week of the 12th through the 18th, which is National Nursing Assistant Week. So you won't want to miss it. Until then, thanks for tuning into the Q's podcast. Take care, stay compliant, and keep delivering the exceptional care that your residents deserve.